Dr. Brada was a professor of clinical oncology at the Institute of Cancer Research and the Royal Marsden Hospital in London, and a professor of radiation oncology at the University of Liverpool and Clatterbridge Cancer Center. He retired from clinical practice as currently is an honorary clinical fellow at the University of Liverpool. He was a leading national and international expert in neuro-oncology and thoracic oncology with expertise in development, evaluation, and implementation of new technologies. Dr. Brada served as president of European Association of Neuro-Oncology, president of ASTRO, and elected as one of the founding fellows of European Academy of Cancer Sciences. He's been involved in early development and implementation of stereotactic radiotherapy, published on technical aspect and long-term clinical outcomes, as well as key studies of late toxicity and cranial irradiation. He has evaluated chemotherapy and radiotherapy in glial tumors, including initial studies of temozolomide. Later in his career, the focus was on lung cancer, developing and testing novel technologies, including motion management techniques, high-precision irradiation, and population studies on lung cancer radiotherapy. Dr. Brada has a long-standing interest in improving methods of care, with studies resulting in changes of clinical practice. He also evaluated novel technologies through systematic reviews, which generated heated debates. So we are hoping for heated debates today. He has authored and co-authored over 280 publications. So Dr. Brada, please.
Sharon, thank you very much.
Yours.
Thank you very much for inviting me. It's not here, it's an evening, and for you it's lunchtime, so enjoy your lunch. I'll try not to disturb it too much. I'm a clinician who has worked very closely with physicists over my career. But today I'm going to give very much a clinical talk, but it obviously relates to technology of radiotherapy. Just to put you in the picture, I've worked on, I will be talking largely about stereotactic radiotherapy, and I wasn't the first to do it. I was very early implementer in the UK. I think my first patient I treated, it was in 1989, so it's, you know, it's an old technique, and but I did follow Montreal. I think Montreal was well before me, with Dr. Podgorsak developing the technique there prior to us using it at the Marsden. Now, the technology has been, as you know, increasingly used. I started in the brain, and it's gone into the treatment systemically. And I therefore want to focus on the oligometastatic disease where it's used. And you can see the question that I'm asking. Is it, you know, how real is it? And I'll try and provide you with some clinical evidence whether the concept actually exists and whether we're, you know, doing the right thing. So oligometastatic disease is a concept. It's not defined. It's a consensus view that it represents one to five metastases, although, you know, some people don't like it and they might like more metastases. That's all called oligometastatic disease, and it could be one or in multiple organs. And as you know, the concept was first raised in 1995 by Hellman and Weichselbaum, and the concept is shown here, and I'm sure you're familiar with this. If there are say 2 or 3 metastases shown here, the belief is that there is that the disease is confined to those metastatic sites, and only much later in the development, in the development of the disease, it becomes disseminated. And obviously the alternative view is that few metastases are just a prelude to disseminated disease with multiple metastases elsewhere, shown here. Now, if we believe in the concept of oligometastatic disease, that the disease is only what we see on the current imaging, and obviously there's a limitation what we see on imaging due to the resolution. If we believe in that, if we then treat the individual lesions, we should stop the disease should essentially be cured, or at least the disease should be delayed to such an extent that the development of metastatic disease elsewhere would either it's stopped or it doesn't develop. And if that is the case, SBRT or stereotactic body radiotherapy should lead to improvement in survival. I'm not debating at all that giving high dose radiation to individual lesions actually controls the individual lesions. I don't think we're debating it. It's an effective treatment for the lesions that you're treating. But the question is, if there is a concept of oligometastatic disease, is there evidence that treating oligometastatic disease actually improves survival? And that would be the proof that the concept is correct. SABR or SBRT is, next best thing. It's become extremely popular among technically minded radiation oncologists, and certainly about private radiation oncologists. If you charge for each lesion you treat, it'll be good for your income and for the institutional income. So it's been growing in popularity. And you can see this. I've just done a kind of rough calculation up till about 2023. I haven't updated it, that there's almost an exponential increase in the number of publications that relate to it. So let me just describe the oligometastatic disease. There are essentially, you can divide it into two groups. So this is just diagrammatic representation of a course of disease, a patient with malignant disease. And you can either have metastases at the presentation, which is essentially stage 4 disease. But if you are interested in this SBRT, you call it synchronous metastases or synchronous oligometastases, or it's at the time of disease recurrence with a controlled primary disease. The disease recurs at few sites, 1 of 5, and then it's metachronous oligometastases. And I'll try and separate the evidence for these two groups of patients. And what we really want to show that from the time of diagnosis and primary therapy, if you use SBRT, there is improvement in survival. So it's shown here, or from the time of diagnosis, recurrent disease, there is evidence of improvements in survival from the same time point. And the only way to do this appropriately is to do a randomized trial where patients with either synchronous or metachronous oligometastases are randomized into SBRT plus standard of care versus standard of care, which in general means systemic anti-cancer therapy. So it could be hormone therapy in breast cancer, or targeted therapy in lung cancer. Mostly it would be chemotherapy. And it can be either done sequentially, that start with SBRT followed by standard of care, or you can do it concurrently, or you can do it with standard of care first. Let's say there are slightly larger metastases, and you follow as an adjuvant treatment with SBRT, either in the recurrent or primary setting. So why do we need a randomized trial? Well, I think most of you that are involved in academic work will understand it, that it avoids any bias. And there are lots of studies that suggest that single arm trials in patients with oligometastases show prolongation of survival. And is that really the case? Well, I show you the problem, and I'm sure you're all aware of it. So if you've got recurrent disease and you measure the effectiveness of your treatment at this time point, at the time of recurrence, the survival. Sorry, I'm trying to show you with an arrow, and the computer has its own mind. So it seems like a hard endpoint, survival. And certainly the end is a hard endpoint. The question is, where is the beginning, from which you measure the life expectancy? Well, if you have a policy that does that, you do frequent imaging, and you have a policy that you only see patients when they present with symptoms, or you have a policy where patients have very frequent imaging, the you if you might show that your patients that have been treated with SABR at this time point is longer compared to survival of this group of patients, but actually they might live to exactly the same time point because the diagnosis was made earlier. So the actual so that you get a bias in terms of lead time bias that leads to apparently better results if you only rely on phase 2 studies. So what you really want is randomized phase 3 trials. And the question is, do we have them? And the answer is there is up till now, and I haven't checked in the last week or two, and they've been published. Up till now, there have not been any published randomized phase 3 trials of SBRT. What we have is a randomized phase 2 trials. And I need to acknowledge that there are a number of randomized phase 3 trials that are currently ongoing, some in the UK, some in the States, I'm sure some in Canada, that are designed to answer this question. But I'm just going on the evidence that exists at present. So we only have limited evidence at the moment, and I'm going on that evidence. So what we have is randomized phase 2 trials. And as you know, there are many problems with phase 2 trials. They contain small numbers of patients, lead to the risk of the arms not being equally balanced. And because of the small numbers, they are statistically unreliable. So what I want to do now is to go over the trials that exist, and I've listed them by site of disease and whether they are as adjuvant treatment, that means as part of the synchronous, as part of the disease at presentation, or metachronous at the time of recurrence. And I'll go, as I say, I'll go over these in some detail. I'm sorry, I can't. What I would really like to do is to ask you whether you believe that there is evidence that SBRT prolongs survival in patients with metastatic, with oligometastases. I don't know if somebody is in Glen. I want to show what the people can raise their hands or can speak. I'm quite happy to hear. Anybody wants to express their view? Do you think there's evidence for survival benefit? Eve, do you want to?
Yeah, I can speak up. I mean, we can do a show of hands here if anybody believes in that question in the proposition or not. Otherwise, we can look online as well for.
Okay. Well, let's.
We've got a minority of proponents here, and I think a lot of shrugs.
Okay.
So we'll take the uncertainties as saying there's some doubt as to whether or not there's evidence. And we've got one of our more senior physicists in the back who's sort of subtly shaking his head.
Okay. But that's really good. I'm very pleased about this. I can tell you that in my clinical practice, and as you know, I'm retired now, but in my clinical practice, my colleagues who are involved with SBRT all believe there is a survival benefit, okay? And they want to treat more and more patients. So that's where we are, and that's kind of basis of what I'm trying to tell you. So let's start with this table, and I'll just take you through it step by step. And the ticks means the number of trials, and O probably just means none, okay? So let's look at the mixture of trials. And what I'm talking about is what's called basket trials. And if any of you will read my editorial that's just come out in the Red Journal, I call it tumor agnostic trials. So any patients with oligometastases are put into these trials. And the most famous one, and I think the first one that's been published, is the Sabre Comet trial. And, it's a Canadian trial primarily. As you can, I've just shown you the schema of the trial. The first thing is it's a small number of patients, roughly 100. It's 99. I don't know why it didn't go to 100, so it's 99. And it has a 2-to-1 randomization. Now, 2-to-1 randomization is a funny concept. If you want a proper randomized study, you do 1-to-1 randomization because you should believe that there is equipoise and there is no difference between the two arms. And 2-to-1 randomization often is done, certainly if a new testing technology, in the belief that your new technology is so good that you can't deny the treatment to a large proportion of patients. So you kind of weight your wonderful new treatment, you weight it so your patients will get this really wonderful new treatment. It might kill them for all you know. I'm not saying that Sabre does, but that's based purely on a belief. Now, there is a reason for 2-to-1 randomization sometimes when you use new drugs, because it provides you, in a phase 2 study, provides you with more information about the potential toxicity of a new drug. So it provides you with that information. But it should really not be done, as far as I'm concerned, as a primary trial to look for effectiveness. Okay, so that's the first issue. The second issue is that I've shown you there are 3 publications. So you publish it once, and if you think it's wonderful, you publish it again, and then you publish it 3 times. And if you publish something 3 times, it's like putting it on social media, it gets amplified and people don't believe that it's, it must be if it's 3 times, it must be more true than if it's once. Okay, so what does the trial show? So this is the standard treatment. So the patients
Can I just ask a question?
Yeah.
Is all the 3 publication based on the same results in this case?
They are updated, okay? Updated results of the same trial. So they do a year later, another 2 years later, okay?
Okay.
So, and I think the main noise came from the first publication. First of all, I think it was presented either at Astro or ASCO. I can't remember where it was presented. And then very quickly, there was a publication in Lancet. And, and there's a sort of, as you know, you get, if it has a higher impact factor, it must be closer to the truth. So if it's a New England journal, you can't possibly challenge it. If it's Lancet, it's almost as good. And if it's in Red Journal, you can question it. So what did the trial show? Well, it showed I've just taken the statements from the abstract, okay, the summary in Lancet. And I'll read it to you. So the median overall survival was 28 months in the control group compared to 41 months. And then they give you some confidence intervals in the Sabre group. And then the interpretation, which is essentially the conclusion, is that there was an improvement in overall survival, which was the primary endpoint. Now, anybody who's statistically minded will know that actually it's not true. Because actually, even in this, as it's shown, the p-value is more than 0.05, so it's not statistically significant. Therefore, statistically, there is no difference. And if that is the case, you can't say that there's a survival difference. It's just not acceptable. I mean, I don't know how Lancet ever allowed this to be published. So I'm just giving you a lesson in how to read papers. Just because it's the Lancet doesn't mean you shouldn't be reading the detail and the statistics of it. Okay. Well, let's look at the actual results as they are published. And they are here. And you can see on the left side is progression-free survival or tumor control. So it shows that, the lesions that you've treated actually are controlled for a period of time. So there is an improvement in progression-free survival. And on the right-hand side, is there a difference in survival? Well, they give you the right statistic, which should be a log-rank analysis of the 2 curves. And actually, there is no significant difference in the log rank. And just because there is a survival difference at the median time point is kind of completely misleading you, because there are very few patients at that point in the curve, and it separates, but it means exactly nothing. So it was a very misleading publication. And it should not have been, it should have been published, but it should have had more strict a review process rather than saying, so people just read the abstract. So from then on, everybody believed there is a survival difference in patients receiving SABR. And, you know, they say it was 100 patients, not really dealing with some of the detail. Well, it was published again. So this is the second publication in JCO. And now in the log rank analysis, the curves do separate and there is a survival difference. Okay, so yes, it did prove to be the case. And there is a survival difference. And for the non-believers, they did again 2 years later, and the survival difference remains. But obviously the curve does continue to go down rather than, you know, there's a plateau. So it's not kind of cure. It's not a cure. So is there really a survival difference in this phase 2 study? So on basic statistics, it would appear to be so. So let's look at the actual patients that were randomized. So the problem with 2-to-1 randomization is that unless you stratify for all the factors that you need, there will be some imbalance, and they were not able to stratify. They certainly didn't stratify by the tumor type. So if you go down the list, you can see there is more in the SABR group. There is what? More breast cancer. And the other one is more prostate cancer, a lot more prostate cancer. And in terms of number of brain metastases, again, the SABR group had fewer metastases compared to the control group. So there is a very significant imbalance in the groups. And in the last publication, you actually learned the truth, which is if you look at the people who survived beyond 5 years, so they don't tell you exactly the details, but they tell you that those people that survived 5 years, so 5-year survivors without progression, there were 25 of them. And of these, there are 11 that were without progression. And which is the predominant tumor type? It's prostate cancer, and the second is breast cancer, and there are obviously some lung cancer cases. So all you see is that patients with prostate cancer have a better prognosis, which we know they live for years even with disease, and it doesn't tell you that it's the SBRT that's led to the prolongation of survival. Means the curve that I've shown you before, at the end of the curve, there were predominantly prostate cancer patients. Okay, so yes, they live longer, but it doesn't prove that it's the SBRTs that was the result. So this is the first trial that really kind of is widely quoted, and it was, you know, it was laudable that it was done and it was correct, but it has statistical flaws, and unfortunately, as it stands, it does not prove there is a survival difference. Now, there are other trials, and some of them suffer from the same problems. They're basket trials, and they've not been stratified by the type of disease. So this is, you probably all recognize it, a Canadian trial that was published last year, but was presented at a meeting a year before. Very similar design. And there was improvement in local control. And if you look at the survival curve, so this is progression-free survival. So in fact, in this trial, there was no difference in progression-free survival using standard log rank statistic, and there was no difference in survival. Okay, so I didn't go into detail how the groups were separated, but they didn't claim a survival. There is no claim for survival difference. And the third basket trial is from the Memorial Sloan Kettering, which only contained 2 diseases, which was breast and lung. So it's slightly purer, and randomized it 1-to-1. And if you look overall, there seems to be some improvement in tumor control. So it's a progression-free survival, so improvement in tumor control. But if you separate it into the 2 disease types, it's only seen in lung and not seen in breast. And if you look at the survival of the same groups of patients, so regardless of the improved local control in lung, there is no survival difference. and clearly no survival difference in breast. So one trial that suggests, of these basket trials, that suggests there is a survival benefit with significant issues, and the others have not shown a survival benefit. And again, they're all phase 2 trials with the problems of phase 2 trials. So let's look at lung. And I start with the trials of adjuvant treatment, synchronous oligometastases, and there are 3 trials. And of those that are inquisitive, I've written the precise references, so you can go and read it up. So let's start with the first trial. So first thing you see, so it's LCT means local consolidation therapy. It could be SBRT or could be surgery. But in most of these, surgery was used less frequently. So I'm using it as evidence for SBRT, but the principle is the same. Very small number of patients. You wouldn't expect a great difference. And these are the patients. So it's less than 50 patients. And if you were looking at the differences in likely prognosis between the 2 groups, which one is better, which is which. So you can see that in the first column, there is more adenocarcinoma. So adenocarcinoma has a better prognosis than squamous carcinoma. So it's weighted for the first group of patients. And if you all probably know that there are patients with targetable mutation in EGFR and ALK, and those have significantly better prognosis because they're treatable with targeted agents. So again, very significant difference in the distribution of patients, and also a slight difference, not such a big difference, in the number of brain metastases. In the number of metastases. So you can now guess which is which. Okay, okay, so these are the differences, and SABRE, which is the LCT, is the group with better prognosis, again, as in the previous trials, even though it was 1-to-1 randomization. And these are the differences in progression-free survival on the left and survival on the right. Yes, it's statistically significant, but it's a phase 2 study of small numbers of patients and imbalance in the prognostic factors between the 2 groups, and there's no attempt to correct for it, which is a shame in most of these studies. No attempt to correct for it. The second, which is the largest trial, is which is a national trial in lung cancer, and it's an adjuvant local therapy, mostly in the form of SABRE. But again, here it's 2-to-1 randomization, and it's a larger number of patients, so larger than any of the previous studies. So patients with metastatic disease, stage 4 disease, having normal chemotherapy and followed by maintenance chemotherapy alone or maintenance chemotherapy plus SABRE, SBRT. And this has only been published in an abstract form, which is always a sign of something, and I will tell you about it in a minute. And you can see that the 1-year progression-free survival and 2-year progression-free survival, there is no statistical difference. In brackets, there's the confidence interval, so it falls well within the confidence intervals. So there is no improvement in local control, and clearly there is no difference. There's unlikely to be a difference in survival. But what I was trying to say is that if you have a phase 2 trial of significant number of patients shown as an abstract 2 years ago, you wonder why isn't it published 2 years later? And there is a issue that you will all know about, which is a publication bias, and positive studies get a preference in being published compared to negative studies. So this is a negative study. Where is the paper? They're probably finding it hard to get it published in a good journal, which is sad. Okay, and the last is a study of patients with a mutated lung cancer. I can assume that all you physicists know about targetable mutation. There's a proportion, 10 to 15% of lung cancers that have a mutation either in the EGF receptor or in ALK, and there are others that are being discovered, ROS1, and there are targetable agents which are oral tyrosine kinase inhibitors, which actually stop the tumor cells from proliferating. So it's very effective oral treatment, and there are first, second, third generation of these agents, and they achieve long-term disease control but not cure. Ultimately, patients become resistant to the treatment, but initially they are highly effective. And the question that's been asked is whether in these patients, the addition of SBRT and local radiotherapy would improve survival compared to the systemic treatment with the tyrosine kinase inhibitors alone. And I won't bore you with the exact types of inhibitors, but they are first generation, second generation, third generation, and the current one is called osimertinib, and it's the most effective, but still only temporary effectiveness. So this is the results, and doesn't it look wonderful? On the left side, you see that it improves disease control, and on the right side, there is an apparent improvement in survival. Okay, blue means with SBRT, and the red means the tyrosine kinase inhibitors alone. Isn't it great? Well, is it? There are problems. And I want those of you that are statistically minded, if you look at these sets of curves, you smell a rat. As somebody who's been done clinical trials over some decades, I'd say there's something really strange going on here. And what is strange is that there is a plateau on a curve. So these are patients with metastatic disease, and you can see not a single patient recurred in the first 6 months, and not a single patient died in the first 6 months. And it's completely unheard of in any metastatic disease. There are patients you put into trials and they die. You start treatment and it doesn't work and they die. And what the initial plateau on a curve means is a selection of patients. There is no way, if you randomized at the 0 point, there will be no patients that actually die and no patients progress. There's some selection bias that's led to a plateau. If I see a randomized trial with a plateau at the beginning, I'm extremely suspicious what's happened. And as a reviewer of journals, I would not accept that study. So that's the first issue. Now the second is that this is a trial of the first generation tyrosine kinase inhibitors versus the third generation. So osimertinib is the kind of newest. It's been around for a few years now, and the comparator arm is the first generation. So that it shows you that, first of all, it shows you that patients do actually die early on. There are patients who die in the first 3 months. The curves don't go flat. So what we want to know, so the patients in this trial were treated with these agents, not the second generation or third generation, but treated with the first generation of agents. So what I've done is that I superimposed the first generation curve, first and second generation curve, onto the plot that's been shown, and it's completely unlike. You have to believe me. I have the time intervals are correct for the dotted curve, and there is something really strange going on. In this particular publication, the tumors do not behave. The disease doesn't behave as you expect. EGFR mutated non-small cell lung cancer. So something strange is going on. Okay, my antennae go up, and I can't explain it. And then there is a third issue. In this study, they did not only use SBRT, but they also used thoracic radiotherapy to the primary site. So they may have metastatic disease, which they treated with SBRT, but they also treated the lung and the mediastinal lymph nodes with conventional fractionated radiotherapy. And you will know that there is you will know that there is a trial in this group of patients with mutated targeted, with lung cancer with targeted mutation that have received radiotherapy in a randomized way. So the question was, does thoracic irradiation improve outcome in this group of patients? And the answer is yes. Okay, so this is a separate trial, not the SBRT trial, that shows that if you use thoracic radiation, there is some improvement in life expectancy in this group of patients. So if we come back to the original curves from this study, reasonable number of patients, but many questions about it, both in terms of selection bias, in terms of relationship to what you would expect, the natural history of patients being treated with the same agent. And thirdly, that there are two additional treatments and you can't disentangle which one it was. Was it SABR or was it the thoracic radiotherapy? So again, it does not provide you with evidence that SBRT prolongs survival. So this is all about lung cancer. And I want to move on to breast cancer. And the story in breast cancer is much simpler. And it's shown here. And there are two studies. There is a NRG-BR02 study. So it's the study I've shown you already, where patients with breast cancer with fewer oligometastases are compared, you compare standard systemic therapy with systemic therapy plus SBRT. And this is recurrent disease. So, and you can see that there is no difference in survival or progression-free survival. In fact, if anything, the actual numerical median survival seems to be worse in the SBRT group. I'm not trying to tell you that it's worse, okay? So there is no difference. And I'm going to give you another example of what I said before. This is a trial that was first presented 4 years ago in abstract form, and it's still not available as a publication. Okay, same publication bias issue of a negative trial. And the second is a selection of patients from an extent study would only had breast cancer. It's been published. And again, I don't need to go into the detail. You can see there is no difference in either survival or progression-free survival. So most people would accept, I think, that on current evidence, there is no benefit in SBRT in patients with breast cancer. It may well be because there are so many systemic treatment options and they're increasing. So it's unlikely dealing with a few metastases you happen to see is going to make any difference. It's really life expectancy is dependent on the systemic treatment that you use. Okay, so that's breast cancer. Prostate cancer is slightly more difficult because of the very good prognosis of patients. And these are the studies, and I'm just going to show you in an outline form. So this is adjuvant SBRT in patients with metastatic prostate cancer, and there are two studies, reasonable number of patients, certainly in the first, smaller number of patients in the second study. They all show progression-free survival benefits. So again, tells you that if you treat individual metastases, say in the bone or soft tissue metastases from prostate cancer, you can achieve some additional control compared to hormone therapy alone. But in one study, there is definitely no survival benefit, and the other one has not yet been published, so we don't really know. But they survive a long time, and there are other treatments available, systemic treatments available. So it will take a long time to know, but there is likely to be a survival benefit. So I don't know at the moment, but currently there is no evidence there is a survival benefit. And the second is the patients with recurrent disease, and it's pretty much the same story. Small number of patients, no survival difference demonstrated. It just demonstrated that it controls the disease that you see, which is not surprising. We know radiotherapy is an effective treatment. There are two more studies I want to mention very quickly, and then there's a study on cancer of the esophagus. This is patients with oligometastatic disease with controlled primary, so recurrent, and So this is the standard design as before, and there seems to be some survival difference. So on the left again, progression-free survival difference, and there is some survival difference. Small numbers. It's a signal. Why would it work in esophagus and not in other sites? I'm not sure, but this is as it is, and clearly still needs a randomized phase 3 trial with sufficient numbers to show it. And I'm not going to dissect it anymore. This is as it stands, and I didn't see any bias that I could pick on. And the last is cancer of the pancreas, terrible disease. And again, same design. And here there is no, again, evidence of improved disease control, but no survival difference. So these are trials. I'm not going to bore you with any more detail of the studies. I take it you got my message, what I've tried to say, and the message is summarized here. N means no, and yes, and the size of it means very big yes or very very small yes. So actually, overwhelmingly, at present, on the basis of phase 2 studies, there is no clear evidence, even though the kind of noise out in the street and in social media and among people who practice SBRT is that it's really good, and you should be offering it to patients. So my conclusion is that there is currently no proof that oligometastatic concept is correct. I'm not telling you that I know that it doesn't exist. We still have to wait for the phase 3 trials. And again, they're very slow in coming. There are some that should have been published by now. I was involved in a lung trial in the UK before I retired some years ago, and I'm surprised that it's not out there. And I always have suspicions if something is not published. Why isn't it? Anyway. So this is the status of the current evidence. I hope, is it a myth or reality? I've explained what the reality is. Is therefore oligometastatic concept a myth? I'll leave it for you to decide. How do we deal with it? And what is the reason why there's kind of so much mythology around? And I hope I've demonstrated to you that there are poorly designed and analyzed studies by enthusiasts, and you have to be very careful. Don't just read the abstract. Please read the whole paper and look at the statistics. I mean, I have one other bee in my bonnet. People, if they have curves that don't suit them, instead of doing proper analysis using log rank analysis, they do hazard ratios. And hazard ratios are only appropriate if there is a proportionality between the two curves. And if you have curves that kind of cross over and, at some point they separate, that's wrong test. And it doesn't tell you statistical significance. And I hope I demonstrated that there is a publication bias in favor of positive results, particularly with new technologies. Lancet and all these journals like new technology, that it's going to cure more patients with cancer. It's wonderful, but actually it's a publication bias that we know about. And how can we deal with it? Well, I think in current climate, it's extremely difficult. Yes, I think there should be an improvement in peer review process, but the way it's structured at the moment, I don't have much hope that it's going to happen. But at least you should read it very critically. So critical reading is what you need to do. And there is a need for these large phase 3 studies, which are on, which are happening now. And hopefully they will give us the true answers. So I'm sorry I spoiled your lunch with telling you some challenging things, clinical challenging things, and doesn't mean you shouldn't be doing SBRT, but the doctors currently should explain the real reason why having it. Yes, it achieves disease control, and if it's responsible for some important symptoms, it's a reasonable treatment. But telling people that it improves their chances of long-term survival, currently there is no evidence. And of course, as you probably know, there are trials that show, say, for example, in bone, that it's no better in terms of palliative treatment compared to conventional single fraction palliative treatment. So yes, it's great technology. We do need to do it, but we do need to prove that it's of benefit to our patients. So thank you very much for your attention.
Thank you so much for this a very exciting presentation. So I have a lot of questions. I see that of all our radiation oncologists, one showed up, Dr. Bahorich. I had hoped that more SBRT enthusiasts would be with us today, but I've heard that radiation oncologists at the Gland site, they are invited to another event today, unfortunately. I will save my questions to the end, giving the students and others.
I'm going to stop sharing so
Yes,
we can
I
actually
think,
see each other as we
yes, I
speak,
think
okay?
that's much better. Yes.
Okay.
So,
And I guess people could put questions into the chat or ask them. So Sharon, you're the controller.
yes, I'm the controller. So please, does anybody have
The question
any
in the audience.
questions in person and in the chat? In the chat, raise your hands, or on Zoom, and then we'll go from there.
There's a question here at the Glen site.
Yes, go ahead, please.
My question is more like related to the use of SBRT as for oligometastatic, but they also don't mention the side effects on these patients. So yeah, it sounds logical that the prostate cancers also have better survival because prostate is growing less invasively or faster than other types of cancer. And you mentioned that they were treating them with systemic therapy or therapy and compared with the SBRT. So I was wondering if they look at the side effects of SBRT versus the systemic therapy, and if it was better, because we tend to focus just on improving the survival or increasing the survival, but what is the quality of that survival?
Okay, so this talk is specifically not about the palliative benefit of SBRT. I've specifically focused on the evidence on survival, okay? And assuming, and I think that's a reasonable assumption, that SBRT to small individual lesions is unlikely to cause severe, has a significant side effect profile. It is not entirely the case because, for example, in the COMET study, there were patients who actually with SBRT who died as the result of the complications of the treatment. Okay, I think there were 3. So I don't know the data, and I don't want to. So I don't want to fill you with misinformation. All I know is in the trial of bone metastases, SBRT was no better in terms of palliation compared to single fraction conventional radiotherapy. Okay, and you're absolutely right. It needs to be tested. It's a wonderful localized treatment. It's used widely for brain metastases. And for example, in brain metastases, there is reasonable evidence that it probably reduces the compared to whole brain radiotherapy, it has less impact on cognitive function. Is it relevant in the majority of patients with brain metastases who have a median survival of a few months? That's another question. But yes, there is evidence. So, but I'm not familiar with the evidence for every site and every palliation.
Thank you. And next, Harry, please go ahead and ask your questions.
Thank you. That was very interesting. I just have a quick question, is that today you're talking only about randomized controlled trials. What do the observational studies say about this question? Because to me, this seems like something that we could at least look at with observational studies.
Well, I think I tried to explain that they are really flawed. Observation studies, you mean single-arm phase 2 studies?
No, I mean adjusted.
What do you mean observational studies?
Retrospective cohort studies. And you spoke briefly about not being a huge fan of hazard ratios and adjusted analysis, but
I mean, I don't fully understand the question, because in a randomized study, there should be in a large randomized study. I'm not talking to you, obviously. I'm talking to the audience. There should be stratification by all the non-prognostic factors. Okay, and that clearly in small phase 2 studies is not done. And what I would have expected for the editors in all the journals is to ask for it, some correction for the non-prognostic factors. And it's complete mystery to me that it's not been done in any of these trials that I've shown, and it's a major flaw in all these publications, and it shows up even journals like the Lancet. Okay. And I try to explain, if in terms of single arm phase 2 trials, that there's such selection bias that you really can't make any conclusion in terms of the effect on life expectancy. And I just showed the example of, if you have a policy of very frequent surveillance with imaging, then of course you're going to have better survival in that group of patients than your historical cohort that would have had imaging, every 6 months or instead of every 2 or 3 months. Okay, so there's a problem.
Right. So just to follow up on what I meant, instead of randomizing to SBRT, looking at people that did and didn't get SBRT and trying to adjust away non-random differences between those groups, has that been looked at?
It may well have been, and I haven't investigated those in detail. Okay, there are obviously large cohorts of patients that have been treated because that people convinced that they treat.
Exactly.
But I don't pay any attention to those. I focus specifically on randomized studies that claim that there's a difference. I don't really. Yeah, it's a signal. I'm sure they show a signal, but they have all those problems of single arm studies, and exactly how do you adjust for cohort that's treated at a different time, and patients were selected in different ways. It's open to so many biases that it's not worth it.
Thank you. Hossein, you had a question as well, so please ask your question.
Yeah, I mean, it was kind of related to what Harry was asking. So thank you so much for the talk. Yeah, I was basically going to say that, okay, like on randomized trials, on population scale, like there's no evidence for it, like they all have the same similar survival benefit at the population scale, but benefit from it, and we are not, like picking those specific patients quite well. So do you think like precision medicine could come and help this out? So, if you could say that, okay, this specific patient that has a specific genetic makeup or, specific immune system precondition, like that patient would probably benefit from SBRT. Do you think that's a possibility, or like?
Well, I fully support what you say, but it has to come from randomized studies. It cannot come from phase 2 studies. Okay, and the big randomized studies that are about to be published, I hope, within the next few years, will then, because they're large enough, they will have some biomarker analyses, and they may show that some biomarkers, some biomarkers may benefit compared to others. There is a problem with all this, of course, is, the multiple testing in large randomized trials that, and there is a type 2 error that you get, by chance, there will be a certain category of patients but seemingly benefit. Okay, so you have to be very careful about it. But it's almost, I think, the evidence that exists is, and I shown you one biomarker defined trial, which is the lung cancer with mutation, which very specific biomarker proven population of patients, and I have a considerable doubt that there is evidence of benefit at present, even though it's claimed.
Thank you. And then next we have Hamid, who's raised his hand. Please go ahead and ask your question.
Thanks, Dr. Dr. Brada, thank you so much for this interesting presentation. Honestly, I haven't heard about this disease. It was too interesting. But based on the problem that you taught during the presentation, I would like to know, based on this problem, among emerging technologies such as biological guided radiation therapy, FLASH, AI, and MR-Linac, which one of these, or anything of these technologies, which one of these technologies do you think will be the most influence in this field in the next 5 or 10 years?
I'm too old to do predictions of new technologies. I've been an academic all my life, okay, and I always believed that technology should be tested the same way as new drugs. So the requirements should be the same. Unfortunately, the agencies that approve new technologies do not require the need for randomized trials for it to be introduced, okay? It's led to lots of problems. And I'm afraid I spent my career being critical of new technologies and saying, where is the evidence? And I could give you even more lectures about protons, if you like. I have followed protons over many years, and there is a lot of misinformation about them. And the evidence is very weak, even at present, that there is, improvement in, certainly no improvement in tumor control and survival, and the evidence for benefit in terms of reduction in toxicity is very slim. And I'm not going to go into detail because there's lots of trials, and I did follow them in great detail. And so yes, we need to investigate new treatments. FLASH is one, is really interesting. But you've got to be very careful. What happens with technologies, it's in the hands of enthusiasts. There is a commercial interest of companies that provide the equipment. There is a commercial interest of the institutions that buy into the equipment and do it. So you need to be very skeptical in analyzing the data of that shows benefit. And it's not up to me. I'm the previous generation. You are the current generation, and you do need to retain critical judgment rather than swallow what is essentially marketing of all new technologies. That's happened throughout my career and it's continued to happen now. Because in the end, you want the best treatment, but you also need affordable healthcare. And just because some wonderful treatment, you have a laser beam that's, shone from the moon onto somebody's, prostate on the earth, it's going to be the best treatment it's ever been. Are you going to accept it? There's going to be a lot of that. Okay.
Thank you so much. So Dr. Bahoric has written something in the chat saying SBRT in prostate cancer tends to delay either hormonal therapy or the next line of systematic therapy, thus side effects associated with it. I'm not sure if you agree, Dr. Brada.
No, I'm not a prostate cancer expert, and I know that it's how it's used. Okay. And but there is no randomized trial yet to show, ultimately you do need to show quality of life benefit and survival benefit. And I do, and if you're radiation oncology, you say, of course you can have SBRT, it's no toxicity at all, and hormones are terrible. Okay. Yeah. I need to see the randomized study that shows the difference in quality of life, not in the individual endpoints that happen to be convenient for you.
Yeah, Dr. Bahoric is cheering, so I guess he agrees with you. But as a professor to all these young minds here, I wonder, where can we find critical reviewing as this type of work? Can you give us guideline, or the students have to review a scientific paper more in detail and dissect it despite of it coming from experts?
I have done it all my life, and I considered that as duty of a clinical academic to do this. It's a free service, and then the journal makes money out of it, and we had to do it for free. And there is really no good training for it. And even if there was, you can see that currently the journals fail in having good reviews.
Yes.
So I can't direct you a publication. If you like, I can give you a talk, next year, and
Yes,
how to
please.
review,
Yes.
how to review, how do we a peer reviewer? I mean, or
Yes.
look at a publication as a peer reviewer. And I still do peer reviews now, and I'm afraid I'm among the most strict of reviewers.
I think I'll organize a workshop, Dr. Brada, on this, because I think it's very important. So Dr. Bahoric has a question. I think we can, because time is ending. Please go ahead, Boris.
Yeah, thank you very much, Dr. Brada. This was one of the best talks I hear for a long time. And I wish you participate in our SBRT tumor boards as well. So maybe next time we are going to invite you there, because there is always this discussion how much benefit we gain out of the SBRT. My question is actually very simple, as a matter of fact. Do you think that what you are getting with SBRT, and we do expose the patient to a risk of side effects, including, like you saw in a cyber comment, that 3 patients died as a consequence of SBRT, can we actually give them something which is less aggressive but yet still effective, like 0721? I know that UK is very known for the 0721 type of schedules. So can we actually achieve pretty much the same thing?
Well,
In prostate, I can almost say yes, because of the low alpha beta ratio.
I mean, I think SBRT is an overkill. You know, the doses that use might be overkill, and that's a kind of starting point. And if your endpoint is tumor control, there is no reason why you can't do randomized trials of lower doses, because you're not going to damage. There's not going to be a disadvantage in terms of survival, because we know even the very high doses currently don't produce survival difference. So why not do lesser treatment at sites where there is a potential risk? So yeah, those trials should be easy to do.
Thank you so
Thank
much. And I will organize a workshop for both radiation oncologists and medical physicists on critically reviewing clinical papers. I think this will be very, very useful for all of us.
I just want to tell you that I gave a lecture in Montreal at the university 26 years ago now.
Well, it's time to revive that.
On stereotactic radiotherapy. So it's it's nice to be back, even if not in person.
I think we can organize it in person. Well, thank you so much for your time, and it was really, really interesting. And thank you. Everybody's very happy with this presentation, and I will come back regarding an in-person workshop on how to critically review